Okay, so we're going to go on to the other operations, if you will, and actually going through what a surgical stapler is. So this is just a foam model of stomach, just so I can show you. Let's see, I'll get up here to the what the staples look like. I don't think the focus goes that well in terms of, there we go. Okay, so you can see 3 rows of little wire sutures. They're tiny, and they are just so tiny. And I'm just going to demonstrate here. I already showed you the stapler a little bit. This is kind of a beastly looking thing, but it has a cartridge here that has 3 rows of wire staples loaded in the thicker cartridge. And we put this in through that laparoscopic port, and we can put it on tissue, and we can close it down. We can also angle it. We can rotate it to match your tissue. I'm going to slide it out just a hair right here. So I'm going to fire this. So it has a little knife that goes down the middle as we fire it. And take the safety off, and then you might be able to see, depending on the focus, the staples going across, getting pushed into the anvil from the bottom up, and that knife is following along just a millimeter or 2 behind, and it's cutting the tissue even as it puts 3 rows of titanium wire sutures on either side. So I'm going to just open this up. It's actually more awkward without my laparoscopic ports. And I'm going to take that off, and you can see there's a few rows of staples left in there where I didn't have it on the tissue. Good, okay. And the knife is pulled back, and then you'll see the tissue here. Let me put that down. So that was the division that was already, and this is the new one that I just made, and it cut down the middle and left 3 rows of wire sutures. And you can see it goes a little beyond the cut so that things are still sealed off. So when somebody says, I had a stapling, that's like saying my house had a hammering. That's just a tool. What we do with a stapler, what tissue we cut or rearrange or put together, is what the operation is. So you can't just tell the ER doc I had a stomach stapling. So I'm going to give you just a brief rundown here on the stomach. There we go. All right, so your stomach is situated down here, but like that. This is the esophagus coming down. This model has a little piece that came off. So this is all one piece, and when you make a gastric bypass, that's the pouch that you make the little, you divide the stomach that way. And this is designed to be a mock-up of the lower bowel that we rearrange. So very quickly and roughly on this model, I encourage you to watch other videos. What we do with a sleeve gastrectomy, which is what I do for 95% of people, is we start down here with our stapler. We divide all the blood vessels around here. We totally free up this outer floppy part of the stomach. Okay. The stomach is about the shape of a small football, or a football, and not exactly the shape, but about that size. And we start with our stapler down here, and we have a tube down through the esophagus, and a tube on this is called the lesser curvature, this is greater curvature. So we want to preserve the muscular part of the stomach for various reasons. And we start down here, and we basically come up snug, but not super tight on the tube, and we make a football-shaped stomach into roughly a banana-shaped stomach. So we remove, this is an ectomy. This really is not like a gastroplasty. This is a gastrectomy. We're removing about 75–85% of the stomach. Okay, what we leave behind empties very quickly. Food passes through here very quickly. You think your food like your stomach like a canteen. It doesn't really digest, but it holds a lot of food. And yes, you eat less, but that's not the key. The real key is that some of the hunger hormones are made up here. Ghrelin is produced partly in the fundus of the stomach. Some of the nerves responding to stretch also are up here. And if you are stretching faster, you get more nerve messages more reliably and sooner and lasting longer about being full. The other thing that happens is food goes down the small bowel faster than, for me, than it did 9 years ago. It goes down, and lower down your bowel, there are also signals of, hey, we've got enough food down here. And if your stomach is emptying normally, it'll empty very slowly, and those signals are slow. And there's a lot of research to show those of us who are affected by obesity, we're not that much hungrier, but we get the message at every meal about 5 minutes later than our skinny friends. 5 minutes at Applebee's, or wherever, I don't mean to pick on Applebee's, 5 minutes if you're eating out, if you're at the cafeteria, that's 5 or 6 more bites of food. If you do that every meal for 10 years, guess what happens? And that's just okay. I'm full now. You guys were full 5 minutes ago. So like I said, we're tweaking these messages, but there's a lot of ways that can vary. So the sleeve is a very good operation for most people. I should get my model back. Gastric bypass, and that's what people think of now. They say I had gastric surgery. They think of gastric bypass as being the operation. What gastric bypass did, and that's why this model was built for this, is we took that staple and we divided the stomach, and we left, it was a little bigger than this. It was the size of a small egg. Now that's not the size of the food that you could eat, because we attached the bowel. We divided bowel, and this is the Roux and Y, and we brought bowel up and plugged it in here. And you could eat over 30 minutes, much more than that size, but the first year that really was about the size you could eat, but not because of the size of the pouch necessarily. And then the Y was we had to bring all this stomach down below still made digestive juice, bile and pancreatic juice came in here. And so we reconnected things down below where we had left a dead end. We reconnected this and made a Y connection. So Roux and Y, ROUX-EN-Y, capital Y, gastric bypass. So that's the Roux and Y, or you'll hear gastric bypass or Roux operation. So that's the American version. There are a few other versions around that are a little different. So gastric bypass has some specific risks, and that's why I don't do them anymore, except in very special circumstances. It turns out this connection is very susceptible to ulcers. It turns out this connection is very susceptible to kinks and emergencies. That's why I didn't get it. I didn't want to be traveling around and in the back country and suddenly get a bowel kink. That was an emergency, and bowel can die. So long-term complications are what kept me from gastric bypass, and that's why I only have stomach surgery for the sleeve. The other thing though, if you have a Roux-en-Y gastric bypass and you have some weight regain 10, 20 years later, we've already done a lot of work here, and we basically have to go take it all apart in order to upgrade. From a sleeve gastrectomy, and now I'm going to talk about duodenal switch. So imagine this is cut off just like a banana-shaped stomach. Okay, we haven't touched the small bowel yet. Well, duodenal switch, and that's my other main operation now, is basically, I say the sleeve is an F-150. It is a very good tool. Apologies to Ford, but it's a very good tool. The F-350 is stronger, but most people don't need to spend the extra money. They don't need the rougher ride. They don't need the worst fuel mileage. You know, an F-150 does the job. That's why 95% of what I do is sleeve gastrectomy now. But I do understand, and the genetics of obesity are tough, and a fair number of people are going to want an upgrade 10 or 20 years later. A few people may want it 2 years later, but I still think it doesn't hurt, because the upgrade is so easy that all we have to do, we haven't touched this tissue. This is the duodenum. This is the upper part of the small bowel. We divide the duodenum for a duodenal switch, and we don't have to divide down here. We do a loop version of the duodenal switch. Be careful what you read about, because there's a lot of versions and people get misunderstandings. But if this is divided, we bring a loop up here and we basically short circuit the bowel the same way you did with gastric bypass, but down here to the duodenum, where there's less of a chance actually of getting an ulcer, and because of the way things are connected, there's less of a chance of getting a bowel obstruction, and there's better weight loss and better diabetes control, over 90% in some studies. And because our modifications, I can't say that it's exactly the same as those studies that show more than 90% diabetes resolution, but for sure it is stronger in almost every version than gastric bypass is for diabetes control and for maximum weight loss. Now, that is not to say that everybody's going to be normal, but I think in terms of maximizing your signals with your genetics, the duodenal switch is the strongest operation we have. To go from that banana-shaped stomach, from a sleeve to the duodenal switch, only takes about 45 minutes, and that's why I like to do the sleeve first, because if you get great results with a sleeve, why do more dividing and sewing than you need to? And there are some risks specifically with the stronger operations. Everybody with any of these operations has a risk of iron deficiency anemia. We're almost all low on vitamin D in the first place, and we worry about bone health. Some of the other specific risks for surgery, I talk about early and late. So any operation, if I'm going to take your gallbladder out, you could, or fix a hernia on you, you could have pneumonia, you could have a heart attack, you could have bleeding, you could have infection, you could have a problem in the area with things falling apart. We just put tissue together, it still has to heal. So when people talk about a leak with surgery with these staplers, whether it's your appendix, or taking out a colon cancer, or doing stomach surgery, all that stuff that we sealed up with those staples still has to heal. And if it doesn't heal, that pops open a little bit. It's usually tiny, but it's enough for fluid to leak out into the abdominal cavity and cause abscess and problems. And getting it healed is really the hardest part. Thank goodness with modern intensive care units and antibiotics, infections don't usually kill people immediately. But then if you can't get it healed, that's where people are in the hospital longer or in a nursing home having to be fed usually through a little tube in their nose. We usually don't do a whole lot of surgical tubes anymore. We try to stay as minimally invasive as we can. But those are the sort of nightmare complications. Now, and I always tell people you would be crazy not to fret. Okay, so fret, but don't freak. And I tell people's families that too. So those short-term surgical risks are pretty similar for these operations as anything. The longer-term risks, the more we become malabsorptive, the more we actually shorten the bowel, the more we make a bypass, the more we have problems with iron absorption, with mineral absorption, zinc, copper. You can get short on those things. Most people they just have to take a bit stronger vitamin and they're fine, but if they don't take it, that can be a problem. Some of the fat-soluble vitamins, vitamin A, D, E, and K, need to be measured and they need to be followed up every year, especially with the duodenal switch, but you can have malabsorption. We don't have many malnourished patients who are at least following up and getting regular visits. Even yearly generally does the job after you're 1 year out. All these operations can lead to some dumping. That's where if you absorb a lot of high osmolar load like orange juice or ice cream or something that your body can just really absorb quickly, that can cause problems with diarrhea. It can cause problems with low blood pressure, sweatiness, belly pain. Anybody with weight loss can have gallbladder problems, gallstones, kidney stones can happen, obviously. Hernias can happen from those little holes, but pretty rare compared to the big incisions we used to make. And then there's diarrhea and foul-smelling stool in some people. I take a little deodorant pill that's a bismuth compound every day, and it definitely makes things less odorous. It doesn't actually reduce the amount of gas you have. But duodenal switch patients quite often really like to take that little pill. That's most of what I have on that. Again, the cost goes up the more staplers we use and the more time we spend in the OR. That's another reason to start with sleeve as opposed to some of the stronger operations, because if you're self-paying especially, you save a little money and you probably have a little less risk of, a small bit less risk of spending extra time in the hospital. I think that covers it for the basic surgical components. So I'm going to talk a little bit next about after surgery.